angina, ischemia, and infarction. Some of this would pretty much be something that you would have remembered in your general module. The other thing is to pretty much be familiar with the causes and the predisposing factors of ischemic heart disease, and to explain atherosclerosis as the main cause of the ischemic heart disease. And then to describe the pathogenesis, the effects, and the complications of myocardial infarction. What I'm going to be introducing in this lecture is what is termed the acute coronary syndrome, which is the common terminology for ischemic heart disease. And the main disease within the syndrome is the MI, which is your typical heart attack. And we're going to focus on that particularly. But there are other disorders within that syndrome, but we'll touch on that a bit more. And then finally, we're going to go through the biochemical markers in diagnosing and prognostication of myocardial infarction. So this is, although it's pathology, when we talk about the pathogenesis later on and looking at the histological slides, but it will be more geared to a clinical type of lecture because we're going to be focusing on the biomarkers. Okay. So by definition, you're seeing here, you've got ischemia, infarction, and angina. Ischemia really is just the lack of blood supply going to the tissue, whereas infarction is having a long enough ischemia to actually cause cell death. So infarction is not reversible. Ischemia is reversible. Okay. And the other thing, when we talk about any heart symptoms, you'll hear in the clinics or in the wards about angina. The full terminology is angina pectoris, and this is just sudden pain, and that's usually around the chest, or it's a discomfort, and that's because of ischemia. Okay, and angina does not come with infarction, so that means it's just ischemia. So if there's any ischemia to the heart, it's called an angina, and that angina means is that particular pain. And it's a very classical, typical pain. Normally, when in our clinical setting, if someone presents with chest pain, you have to assume that person has an MI or a heart condition until you've proven otherwise. You prove otherwise by looking at the ECG findings, and you look at the biomarkers. If they're not elevated, if ECG doesn't show any ischemic changes, then you can safely send that patient back home with knowing that that chest pain is not really coming from the heart, but it may come from elsewhere. So that's usually the main thing. And the chest pain, if you remember, people are always saying it's on the left side, it radiates to the left arm, or it goes up the neck. But the typical type of chest pain is not sharp. The MI type of chest pain tends to be, they will explain it as if somebody's pressing on their chest. That's the kind of pain that they get. So if, let's say, somebody comes in and they point and say, I have chest pain, it's right here, they're specific. So we know that most likely might not be a typical MI, but it could be something else related. It could be lungs, it could be the muscles, the intercostal muscles, etc. But if they say, I have a chest pain, and they're covering all over their chest with their hands because they can't pinpoint where the pain is, that's usually a typical type of what the description of chest pain that they would have. Okay. So if you look at the definition of ischemic heart disease, it's really a group of closely related syndromes that results from ischemia. And what happens is it leads to an imbalance of blood supply and demand of the heart, particularly the oxygenated blood. Okay? It results from either a hypoxia or anoxia, reduced availability of nutrition, or inadequate removal of the metabolites. So those are the common types of ischemia that can the common types of things that can actually result in ischemia. Epidemiology. We have tried to curb this worldwide, but unfortunately, as more and more processed foods are being introduced, we're becoming more and more sedentary, mainly because we've got so much technology that's assisting us. So for as long as we are very much dependent on this, we tend to see an increase in MI or in ischemic heart disease. So currently, we have not ever seen it go down. It has always consistently been on an increase. It accounts for about 80% of cardiac mortality. and a third of all death. So this is, if you look at if you ever read the WHO reporting or our Ministry of Health when you report, they will mention non-communicable diseases, the NCDs. It falls under the NCDs, and it accounts for the majority of the main problems of non-communicable diseases. So the main aspects of how you can get this ischemic heart disease is really revolving around three coronary vessels. You'll see here you've got the LAD, the right circumflex, and the left circumflex artery. Okay, so you have LAD, RCA, and LCX, and your LAD tends to be the most common that actually gets obstructed by atherosclerosis and then leads to ischemia. And you would have known that that's one of the larger coronary vessels, and that supplies the anterior part of the heart. Second one would be the RCA, and then finally the left circumflex. Okay? So those are in the order of the common occurrence of obstruction and leading up to ischemia. So if you look at the mechanisms and causes, there are three main causes. Number one is either having a reduced coronary blood flow, and that's more than 90% of the cases. And it's most often a combination of atherosclerosis, and then you get the blood vessel spasming, only because the blood vessel wall no longer functions normally. So it tends to just vasospasm at odd times. So those are the things that lead to that reduced coronary blood flow. It could be a thrombosis, or it could be both. So if you tend to just have atherosclerosis and a bit of vasospasm, that's typically your angina. If you have a full-blown thrombosis and it obstructs more than 75% of your coronary arteries, then that might lead you to a myocardial infarction. Okay. That's the most common cause of a reduced coronary blood flow. It's an atherosclerosis that can actually rupture and cause thrombosis, or it's just there causing vasospasm. Uncommonly, the uncommon causes of reduced coronary blood flow would be anything else that can obstruct it other than atherosclerosis. So it can be any inflammatory response, like an arthritis, an emboli coming from elsewhere, that means a thrombus somewhere else coming to the coronary arteries, any cocaine-induced vasospasm, shock, systemic hypotension. Those all drop your blood flow to the coronary arteries and supplying your heart. So that's the main one in terms of the cause. The second one is an increase in myocardial demand. So if, let's say, you have hypertension and you have never managed the hypertension very well, chances are that person can be at risk of a myocardial infarction, because you have now increased the myocardial demand, because as you have hypertension, your heart tries to compensate against that really high pressure, so it tends to undergo hypertrophy. So the left ventricular hypertrophy will definitely increase your myocardial demand, so the heart needs more oxygen that you are unable to supply. The other one is tachycardia, and tachycardia also takes up a lot of energy, which requires a lot of oxygen, and therefore you're increasing the blood vessel demand. The third one, which is the least common, is the hypoxia because of diminished oxygen transport. So if you have severe anemia or significant anemias, living in higher altitudes where you have low oxygen binding, then you're definitely going to actually have low oxygen capacity sending to the heart, and that's how you get the hypoxia. So those are the three main causes or the mechanisms that can cause that imbalance of demand and supply. So this is just showing you now the gross picture of what a coronary artery thrombus looks like. Okay. Can you see this right here?
Yes, doctor.
Yeah.
Okay. So this is a longitudinal section. They cut it longitudinally and they opened up the coronary artery vessel. And if you can see in there, it looks like a worm. And then surrounding it is dark red. That worm-like thing is actually the thrombus that's still intact. And surrounding it is a bit of the blood. So that's showing you the actual thrombus all along the coronary arteries. And then this is more of a cross-sectional cut. So a cross-sectional cut, this is the coronary artery, and you can see that it is completely obstructed with thrombus. So this is these are what you will see in patients with MI. So in this particular case, the patient has passed away from an MI, and the postmortem was done, and that's what you're seeing there. Okay. Again, this is your coronary artery, and it's just showing you, if you can see that there's narrowing of the lumen compared to this one. And that's just the narrowing of the lumen because surrounding this is your atherosclerosis. You don't see thrombus here, but that's just mainly the atherosclerosis narrowing it down. And this, if let's say the patient was a live human, you would know he would pretty much have some form of angina. Okay, but not really getting a myocardial infarction. Okay, this is now going to the histology section. And what you're going to see is this is normal. Nice coronary artery, no evidence of atherosclerosis. It's really beautiful, nice large lumen. And then you get to here. If you can see this, you know what this is, right? What's that?
Yes,
What's this?
Fatty streaks.
That's your fatty streaks. That's right. Okay. So your cholesterol clefts are here, or the crystals are here, and you can see the thickening of the tunica media, and sorry, you see thickening of the tunica intima layer, and therefore this is your atherosclerosis, and it narrows your lumen. Now, if you go to this stage, what's here? That's what's there. Okay, it's a thrombus. Can you see those the crystals around here, the clefts? They're like sharp, narrow needle like. Yeah. Okay, so that's actually your atherosclerosis. It has ruptured somewhere here, and then it has triggered a thrombus. It has triggered a clotting reaction, therefore a thrombus has formed, and unfortunately it has clogged up the already small lumen because of the atherosclerosis. Okay, this is an MI. This is angina. Okay, so a patient will present as angina if the coronary vessels look like this. A patient will usually come in with an MI if the coronary vessels look like this. And usually the cardiologist, their main idea is to shove this thrombus away by inserting the by doing the angioplasty. So they insert that tube to keep the wall open, so keep the lumen open. Okay, so I'm coming to the syndrome now. This is the ischemic syndrome, or what I've highlighted to you before. It is now called the acute coronary syndrome. It differs in the rate and the onset and the severity of your ischemia, or your lack of oxygen. It can be as mild. It can be mild in the form of angina. It can be a bit more severe in the sense that it's myocardial infarction, or it can just be sudden cardiac death, and that's actually myocardial infarction, where the patient dies in less than 1 hour after the event. So you get a sudden cardiac death. So with angina, if you look at this, it's the same pain. So all these syndromes, the pain is similar. It's that substernal, it's behind the sternum, and it's a very generalized pain. It's not sharp, and then it comes on suddenly. It causes quite significant discomfort, and that's usually what is termed angina. But in this case, there is no evidence of infarction. If it's a live human and you want to diagnose that, you pretty much don't cut them open to see the coronary arteries, but what you do is you can look at it through the ECG or through the biomarkers. Okay, so there are 3 types of angina in this case. There's stable, there's Prince-Metal, and there's unstable angina. The stable angina is usually where you have a typical 75% stenosis. You still have the remaining percentage open. So when you have a stable angina, usually what happens is the patient, when let's say they're doing a bit of gardening. So if they're gardening and then suddenly they get the chest pain. And then when they decide to rest for a while, the chest pain goes away. So it's only the pain that comes on after some form of exertion. They start running and then they get the chest pain. And then when they rest, it goes away. So that's stable angina, usually because of a stable plaque. Okay, an unstable angina. Sorry. You have to understand. Yeah, this is different compared to the stable and unstable plaque that Prof. Hafiza might have highlighted in the atherosclerosis lecture. This is a stable and unstable angina. It really depends on your presentation. If it's an unstable angina, it means that what has happened is the patient's at rest watching TV, and then suddenly the chest pain comes on, and he did not exert himself. There's nothing that triggers it, and he just gets it, and then after a while it goes away, and that's usually your unstable angina, and they just can't tell you why or what would have triggered it. So what happens here is that the theory is that you have plaque, and then it actually gets disrupted, and then it forms a clot, but the body is fast enough to actually break down the clots, that it clears up the lumen before an infarction happens. So an unstable angina is actually like a pre-MI. So if the body doesn't break down the clot fast enough, then you will get it. The patient will progress to a myocardial infarction. So that's the difference between stable angina and unstable angina. And with regards to Prinzmetal angina, they call these vasospasms nowadays. This can actually typically happen in patients with hypertension that's not well controlled. The blood vessel again loses its function, and so the walls will just tend to contract whenever they please. So it doesn't respond appropriately. So you can get vasospasms at any point in time, and then you suddenly feel the chest pain because you're not getting enough blood supply. So that's a Prinzmetal angina. So stable angina is when it's triggered by exertion. Unstable angina is it comes on even at rest. But a Prinzmetal angina can get it any other time as well, but it's definitely not because of atherosclerosis, but more of a vasospasm of the blood vessel wall. All this you can pretty much differentiate by the ECG. Okay, so that's looking at just angina, and again, this is more of a clinical approach because it's more symptoms. So if you look at myocardial infarction, this is before we go into a myocardial infarction, let me in general, what it means is it's marked cell death of the cardiac muscles. Okay, and I touch on sudden cardiac death first because I want to get it out of the way. It's the same mechanism. The pathophysiology or the pathogenesis is similar to that of myocardial infarction. It's just the definition is different. It's defined as an unexpected cardiac death within 1 hour of symptom onset. It's because of ischemic heart disease. You have about 75% to 95% with you have 75% have marked atherosclerotic stenosis, and then you have this plaque disruption. That means you would have formed a clot, and it's usually more than one coronary arteries for you to actually drop dead immediately. So more than one coronary arteries would have been affected. A lot of the times it's all three vessels. So the mechanism of death in this case usually is by arrhythmia, just because you've cut off that blood supply to the pacemaker, and so you can get either the VF or an asystole. Okay, so that's sudden cardiac death. So now we move on to myocardial infarction, and this is really a result between that imbalance again of the supply and demand. There's two types. You have what is called the transmural and the subendocardial. A transmural means it's all across the wall of the heart that's affected, and a subendocardial is where the inner third or inner half of the heart is affected. So what happens now is it means that if your coronary arteries are completely obstructed and you don't get enough oxygen at all, then all three layers will not get enough oxygen supply and they're all going to die. Whereas a subendocardial infarct, it just means that you have obstruction, but there's still some oxygen supply from a bit of blood that comes trickling through the blood vessels, and they could supply the outer wall, the outer third, the outer 2/3 of the wall, and the inner third or inner half gets no oxygen supply at all, and they die. Okay, so it can be either transmural or a subendocardial infarction, and that's how you define it. And the other thing is, a lot of the times maybe you get a complete obstruction, But because you were able to the body is able to completely break down the thrombus quick enough, it only affected the outer third, and it salvaged. It could salvage the outer third, but it was unable to salvage the inner third in terms of blood supply. Okay, so those are the difference. So this is less severe compared to a transmural. So in this case, you're just going to see a transmural because that's usually the typical things that we see. We usually see the transmural, but where all the three layers are affected, and you can see this is the pale area of infarct. This is your right ventricle. This is your left ventricle, and it's affecting your ventricles, and that's your infarction. And then around the infarction, you're going to see that red hemorrhage. Okay, again, highlighting the fact that what happens in this case is you get a complete obstruction like so that leads to this. Okay. Am I going too fast, or you guys are okay to keep up?
It's
Okay,
okay.
Doctor.
Okay,
Okay.
doctor.
Okay, doctor.
Okay. So the myocardium here, what this is when they cut it longitudinally. So you're seeing the surface, and then beneath it, and it should be all the muscles. What you're seeing is all this above is actually fibrosis, because you can see it's that pinkish, pale pink. So that's telling you that a scar has formed. Okay, so this is actually an old infarction and showing you that fibrosis has occurred, and below this is your normal muscles. So this is a subendocardial MI, where a portion of the wall is affected and the other portion remains intact because it was salvaged. Okay. Major risk factors. Okay, so we look at the MI risk factors now. Similarly to atherosclerosis, Prof. Hafiza would have highlighted this. We won't go into much detail into it. Prof. Hafiza did cover this, can? It's the same, okay?
Yes.
In terms of the risk factors. And if you can see this, when I gave you my recording of the hypertension lecture, you would have seen the risk factors for hypertension. It's almost the same. So that means when it comes to heart problems, it usually revolves around the same risk factors. So, but the only difference is you have a major risk factor and a minor risk factor. Major risk factor means if you have this, chances of you getting heart disease has a higher percentage. And so the main ones would be high lipids, hypertension, cigarettes, diabetes. Those are the major. That means if you have, the difference is if, let's say, if you have heart disease, if you have a history of heart disease or you have diabetes, you automatically get categorized as high risk patients. And therefore, we control your cholesterol very, very vigorously. Okay. But if you don't have diabetes, or if you don't have any history of heart disease, then we'd have to calculate your risk for heart disease. So these are the minor ones. You have the gender, the age, your family history, whether or not you're obese, whether you have a sedentary lifestyle, whether your diet is poor, and there is such a thing as hyperhomocystinemia, because we know that cysteine actually contributes towards forming the atherosclerosis. Okay, so anyone with that genetic abnormalities is considered at risk of ischemic heart disease. Okay, so this is the most important thing. This is the MI pathogenesis that if ever there's going to be a question out for this, we're going to ask you about the mechanism. Okay, and the mechanism really boils down to 7 steps. The first step in an MI, and I'm highlighting this now, Prof. Hafiza would have highlighted you the pathogenesis of atherosclerosis, and she would have mentioned about endothelial dysfunction leading up to chronic inflammation, and then causing the monocytes to come in, the whole rolling, and then transmigration, converting to macrophage, engulfing, etc., etc. And so now, and then you form your atherosclerotic plaque. Now, this is a continuation after the atherosclerotic plaque has happened. Okay, you'll get a sudden change in morphology of that atheroma or the plaque. So that sudden change in morphology usually is in the form of either you get a rupture, you get an ulceration, you get a fissuring. What all these terminologies means is you've just torn the wall. That's it. There's some form of trauma to the wall, tear, and that's usually because of the pressure of the blood flow. Okay, and when that happens, you are going to now trigger clotting. So you get platelet exposed to the subendothelial collagen, and then your platelet will be activated, and then it will be aggregated, and then from there it will release the ADP, and the presence of ADP will actually cause release of tissue thromboplastin, and then it will activate the coagulation pathway, and then trigger clot. You get the platelet mass leading up to occlusive thrombus, and then you get the MI. So that's the pathogenesis. 7 steps, and these are the steps. Okay. Okay, in terms of the microscopic features now, I have highlighted to you before what it should look like grossly and then microscopically. But if you look at compared to a fresh and an old infarct, a fresh infarct, if you remember your general module 1, an example of coagulative necrosis, they always mention myocardial infarction. So in this case, you should see coagulative necrosis. So what you should see is you should still see the cells. They should still be there, but they don't have a very distinctive feature. You would have lost, you would not be able to see the nuclei. And if you did see the nuclei, it would be very, very faint. You would have lost the striations. The striation, because remember, cardiac muscles have striations for the contraction. So you would have lost that striations. And the muscle cells would be very much more dark pink. And then you should see neutrophilic infiltrate in the beginning of that infarct, because the neutrophils come in there to actually clean up the mess. Okay, so you should see heavy neutrophilic infiltrates. An old infarct, the easiest thing that I had shown you just now was fibrous tissue, lighter pink, and you've got wavy cells, which is pretty much your all the collagens laying down, and that's your fibrous tissues, replacing that normal myocytes. Because you have to remember, heart is actually a permanent cells. So if you have 1 million cells of the MI of heart, in the heart tissue, and then you remove 500,000, you only have 500,000 to work with left. It does not regenerate. So where it has lost, it's going to replace with scar tissue. Okay. So this is what you're going to see. This is the earliest changes that you would see. This is coagulative necrosis. The bands are slowly disappearing. You can see the bands are gone. You can see some of the outline of the cells, but not all. But you can see. Can you see these lines? These lines. These lines. Okay. Those are
Yes.
called the contraction bands. Okay. So that's those are the first. If you see those first few things, and you know that this is usually maybe between 24 to 48 hours of MI, and then those are just the blood air, the red blood cells around. You're not seeing the neutrophilic infiltrates. I think they're somewhere, but they're just focusing on the contraction bands and the coagulative necrosis here. In this section, you can see above, the cells are undergoing the coagulative necrosis. You're losing the nuclei. You can't see them anymore. You've lost the striations. Down here, you'll see the infiltration. But in this case now, because it's already 1 to 2 weeks, you're not going to see the neutrophils anymore. These are more monocytes that will be changed into macrophage. Okay, majority of these, like this one right here, those are macrophage. Okay, that's your macrophage. This is actually your macrophage there. But majority of it is actually your monocytes that's going to be converted to macrophage. And then you should see the numerous capillaries. Oh, I can't remember now where I saw that. But there's not much colonization. Okay, I think these are your numerous capillaries here. I think it's a longitudinal cross section, so you get to see the small, tiny blood vessels that looks like small, tiny straws. So yeah, so those are the things that you should see within the 1 to 2 weeks, because repair is happening at this point in time. Okay. Again, this is what I showed you just now in terms of what you should see on gross. You should see the pallor infarct. Okay, clinical features, I covered it just now. Okay, and then this is just to highlight in terms of that acute coronary syndrome. They divide it into by ECG changes, either a non-ST elevation or an ST elevation, and then usually non-ST elevation is an unstable angina. If it's an ST elevation, it's usually the what we call as an MI, but it's an ST elevation MI, what is called a STEMI. Okay, non-STEMI, which means that non-ST elevation myocardial infarction falls under here. So under here, you can get an unstable or a non-STEMI. And the non-STEMI is the one that they need the biomarkers to confirm that this is actually an MI and not an angina, because treatment are different. Okay, so this is how they actually divide the ischemic heart disease syndrome based on that. So what I highlighted to you before was that there's just angina, there is MI, and then there's sudden cardiac death. In a clinical setting, that's under pathology. In a clinical setting, they divide it based on what they see on ECG, and they base it on whether they see an ST elevation or a non-ST elevation. And under non-ST elevation, it can be either an unstable angina or it could be a non-ST elevation myocardial infarction. An ST elevation is clear cut, is a STEMI. Okay, so that's the main thing. But I'm just going to highlight to you, we will not give you exams on the clinical aspects, but I'm just introducing this to you so you're familiar when you go into the clinical years. Okay. This is a bit of history now. We're moving on to the biomarkers, which is the last part of your objectives. But I'm just highlighting to you, sorry, the first thing is in terms of the definition. Again, this is not in exams, but I'm just highlighting it to you so that you're familiar and you're aware when clinicians start talking and you don't get lost. When I first became a medical student, we used the WHO criteria, okay? And the WHO had several versions of it during the time that it had to, it was given the responsibility to define myocardial infarction. So you can see WHO around all throughout here. And then somewhere in 2000, because the problem was Europeans did it their way, Americans did it their way. Okay, and then we don't know which one we want to choose. So we tend to go with the European more. Okay, so what they now decided to do was they said, look, let's just get together and come up with a standardized definition. So what they did was the European Society of Cardiology and an American cardiology and the American cardiology, I can't remember. The group ACC is for, the American one, and then that's the European one. They came together and they did the ESC ACC definition of MI. When you talk about definition, it's the way that we diagnose. Okay, so that's a guideline that came up. Then after that, they decided to change it, and they changed it to what is called the Universal Definition of MI, so the UDMI. So that's all universal. It's used throughout the world. There's no more American, there's no more European. And so currently what we're using is the fourth UDMI definition. It's a very long definition, and this is the definition of the different types of MI. So they have 5 types now. So from WHO, which was very simple, they just said ECG changes, biomarker changes, and patient has symptoms. 3 things only. And now it has a long series of things that you have to fulfill in order for you to diagnose an MI. So just to highlight to you in terms of how the clinical world has changed the definition of MI throughout the years. So currently we are at the 4th UDMI definition. So when we look at investigation based on those guidelines that I've highlighted just now, they focus on 2 aspects: the ECG, the biochemical markers. Yeah, they can look at other radio imaging tests. Angiogram is now the most common approach, as apart from the clinical presentation. Okay, so those are the investigation. And in terms of ECG, they really look at the ST wave, the T wave, and the Q wave development. Okay.
I'm sorry, doctor.
Yeah.
Can I ask,
Mm-hmm.
what about the use of stress tests?
The use of stress test, that's a good question. Use of stress test is mainly for angina. You're right. We can mention under other investigations here that you have the non-invasive cardiac test, and that would be your stress test. Stress test is only given if, let's say, somebody has these chest pains and then it's like the stable angina presentation or the unstable angina, but you know that they don't have a myocardial infarction because they don't have elevations in the cardiac markers, for example. Then they would proceed to do a stress test. But if, let's say, they've been hospitalized and then they've been scheduled for angiogram, you can see the blood vessels without having to do the stress test. So those are the things. In our lipid clinic, we know what we normally do is those with very high risk, we would send them for stress test just so that they have a baseline reading of the stress test reading, so to see that their stress test is normal, so that there's no evidence of angina at all, and we might repeat it every 2 years, 3 years, depending. Okay, cardiologists don't like that approach because they just think it's just time consuming. So cardiologists also have their own way of addressing. So for them, stress test is only when you get symptoms. But for some of us, we prefer to practice that we identify it before any presentation happens. So you have different schools of thoughts, but we respect one another when we do make the we do make the request. The cardiologists do entertain our requests and things like that. But I think the cardiologist will have a different perspective when you actually go through your cardiology punya training in your clinical years nanti. Okay, so does that answer your question in terms of stress test?
Yes, doctor. Thank
Okay,
you.
all right. So never for MI lah, stress test, because that's a bit too late for us to do stress test. Okay, so now we move on to the biochemical markers. Can you see there's 4? You've got the troponin, you've got the CKMB, which is the isoform specific to the cardiac markers, almost specific. You've got the total creatinine kinase, and why we do total creatinine kinase is because we look at the ratio, the CKMB to total CK kinase. If it's elevated, then you know the ratio is elevated, then you know it is because of MI. And then you have myoglobin. You have all this AST, ALT, LDH that was used before, but it's no longer used now because it's obsolete biomarkers. And this is the historical approach of the biomarkers of ACS. So you have chest pain here. You can do the ECG here, but then later on, these biomarkers came into play. And then later on, AST, CK, LDH, they were all becoming obsolete. CK still retains for as long as CKMB is around, sometimes because some clinicians like to calculate the ratio. So they do the CK not to look at CK only, but they look at it in calculating the ratio of CKMB to CK. Okay? And then you have myoglobin and then troponin. Now we have what is called the high sensitive troponin. High sensitive troponin means that if you look at a lab analyzer, it can only, for example, a lab analyzer can detect only up to this point. The lowest point it can ever detect is, for example, 1 milligrams per liter of troponin, for example. So anything below that, the analyzer cannot detect because it doesn't have that sensitivity to reach down to that concentration. Okay. With high sensitive troponin, what you do is it's still the same concept. You're still measuring troponin, but now instead of the lowest point that they can measure is at 1, they can now measure at 0.01. So that's what it means by high sensitivity. So that analyzer now can pick up really, really, really low troponin levels. So we have come to this stage, which means that troponin has been the way forward in terms of biomarker. So we're just going to go through in terms of the duration elevation. You covered this, right, in biochem?
Not yet, I think, doctor.
Not yet? Okay. So what it's trying to highlight here is in terms of when it comes up after a myocardial infarction, when it is at its peak, and then when it tapers down. Okay. So if you look at this is your myoglobin. It goes up really, really fast. It peaks very, very quickly in less than a day, but then it comes back down to almost normal after 1 day. That's myoglobin. This is your CKMB. I'm just highlighting the myoglobin, CKMB, and troponin because that's still current. Your CKMB comes up almost as quickly as myoglobin, but maybe a 1 hour or 2 hour delay. But it starts to rise. It peaks again because it peaks a bit later. So it's about 1 to 2 hour delay in peak compared to myoglobin. And then it comes down but maybe up to 70. We've seen up to 72 hours, but on average, it comes down after 60 hours. So after 2 days, you're going to see it start coming down. With troponin now, troponin comes up a bit. Hang on, is that troponin? Sorry. Yeah. So it comes up around the same time as your CKMB, not as fast as myoglobin. It does go up quite quickly. It peaks around the same time as CKMB, but if you can see, it remains elevated for longer periods, sometimes between 1 to 2 weeks. A lot of the times it's up to 2 weeks that it remains elevated. And that's troponin. Okay, so now if knowing about these biomarkers, let's go to the advantages and disadvantages of each. So if you look at cardiac troponins, you know what it is. It's the contraction mechanism, one of the proteins involved in the contraction mechanism of the heart. It's not found in blood of healthy individuals, but because of the high sensitive troponin now, remember it can detect even at 0.01. We do have some circulating around because our muscles go into a lot of stress and then it just sheds, but it doesn't mean it's abnormal. So sometimes you can detect it in healthy individuals. So therefore, it becomes very tricky now to determine whether or not you have MI or you don't, because among healthy individuals now, they can detect the troponin. But whatever it is, normally for your case, just understand it should not be found in blood in healthy individuals. It should be completely normal, okay? It's highly specific to myocardium because troponins, you can't find it in any other organ except for the heart. So that's why it's very specific to the heart, which is good because we know that any trauma to the heart, troponin goes up. And therefore, you know that chances are it's an MI. Okay. So we love troponins. Clinicians love the troponins, and they go to troponins for a lot of the times when they want to diagnose.
So, I'm sorry, doctor.
Mm-hmm.
Can I ask? So that means, in a healthy individual, it has to be completely zero. The level of troponin has to be completely zero.
Usually that is the case. But for example, now because of that high sensitive troponin, I don't go into this very much with you guys because I don't want you to know this so much because that's clinical. But out of curiosity to answer that question, with high sensitive troponin, because it can detect much lower and can detect among healthy individuals, the way that they solved the problem was they did they decided to find out what's the normal reference interval for cardiac the high sensitivity troponin T or I. Okay, so they took a big group of healthy individuals, measured their high sensitive troponin, and then they plotted that normality graph, and then they cut it at 95 percentile. So now your reference interval is between that. So which means that it's still present, but you can only, your threshold is if it's greater than 14 nanograms which means that that's 0.014. If that's grams per liter. So if it's greater than that, then they will only consider you might have MI. Okay, so that's the cutoff now because they did it on healthy individuals. So before this, with the troponin one, they determined the cutoff based on patients with MI, because technically healthy individuals should have zero. It should be less than 1. So they don't determine on healthy individuals. They determine on the actual people with MI. But now, because it's become very high sensitivity that you can see it among healthy, they have to do the reference interval determination among the normal first, so that they can know the cutoff. At which point, that now only 5% of the normals actually have that are actually fall outside of that normal range. So, in saying this, where is it? Not found. That's not true anymore. This is only true for the troponins, the conventional ones, which are still being used. Not all centers use the high sensitive troponin, but if it's high sensitive troponin, you can see it in healthy individuals. Therefore, to yang the idea, the range for healthy individuals, you can be from here to here. But because clinicians are so familiar with cutoffs, so they made the cutoff at 14, which is the highest level for normal human beings. Okay, good answer.
Okay, doctor.
Okay,
Thank you.
right. So cardiac troponin, it's it can be used for early. It can also be used for late marker. It can be used for early in the sense that if the patient comes in maybe 6 hours after the chest problem, then you can say, okay, troponin, I can work with that. Troponin should be elevated if there is MI. The other good thing about this troponin is that someone can come in maybe 2 days after the chest pain, just because the chest pain is still there. Sometimes a lot of the patients, they don't want to come in immediately. They'll be like, okay, if I rest a while, it'll go away, this and that. And then a week later, or even if, a few days later, or even a week later, they'll come in. And then they'll say, look, I had this chest pain. It's slowly reducing, but it's still there. So I don't know whether it's a heart attack or not. And so by then, you can't use CKMB or myoglobin anymore because they would have been normal. Because they go back to, for example, CKMB goes back to normal in 72 hours. And myoglobin usually goes back to normal within 24 hours. And this patient has come in 5 days later to you, for example. So you can use troponins because troponin stays within the system elevated over up to 2 weeks. So if they come in late, you can use it to detect myocardial infarction. So it's really good as an early and late marker. And again, what I highlighted before. This is where it starts to rise, where it starts to peak, and the duration that it stays elevated. So the advantage of this is that in terms of its diagnostic sensitivity, it's more sensitive than CKMB. Obviously, for obvious reasons that now are the highest sensitive troponin. It can detect at the smallest levels. So it has not just CKMB, any biomarker. It has a very good diagnostic sensitivity. It is cardiac specific. That means only the heart muscle releases cardiac troponins. You don't have that problem like last time they used AST to determine, but AST comes from the liver as well and from the red blood cells. CKMB technically was supposed to be from the heart, but it can also come from other muscles. Skeletal muscles also have CKMB, so it's not very specific to that organ. But troponin is, and it can detect AMI up to 2 weeks of presentation. The problem with cardiac troponin is that in the early phase, if let's say it's the patient comes in like 1 hour after the symptom onset, troponin wouldn't have the time to increase yet because it starts to increase between 3 to 4 hours. So you might need, if it's negative the first time you measure it, you might have to keep the patient in to do a second test just to make sure that it doesn't go up. So that's the disadvantage of it. And the other disadvantage is the ability to detect late minor reinfarction. Do you understand that?
No, doctor.
Okay,
No.
I thought so. So I'm just going to go back to this. Okay, can you see this is troponin, right?
Yes.
It
Yes.
stays elevated for a very long time. Okay, let's say you have the first infarction. It's here, so it's elevated, right? So CKMB is elevated, right? So then it starts coming down. So this typically remains elevated, but CKMB nicely comes down. And then somewhere on day 48, you have another MI. Your first MI was here. Your second MI was here. Can troponin T be elevated? Difficult, right?
Yes.
Because it's already elevated. So you won't be able to see that second infarct because in your system it's still high. But you can see it if you were to measure CKMB because CKMB already becomes normal at 48 and then you have your second MI. So it should give you another peak at 48 to tell you there's another infarction happening. Okay, so that's what it means by reinfarction. That means there's another infarction happening after the first one. So when you have reinfarction like that, and if you have it within 2 weeks, chances are if you measure troponin, you won't see it because troponin is still high within the system. Okay, so that's when you can start using the other ones, the myoglobin and the CKMB. Okay, is that clear?
Clear, doctor.
Okay, so that's what it means by limited ability to detect that late minor reinfarction, not the new infarct. Okay. Okay, CKMB, this is in the past. Benchmark is the biomarker to go to for myocardial injury until troponin took over. But cardiologists wants to remove this. They say obsolete completely. But we can't remove it because there will be rural areas that can't afford troponin, or the analysis don't run for troponin. So what we do is we still cater for CKMB. So CKMB can be the better alternative to cardiac troponin. If you can't use cardiac troponin, please use CKMB. That's what they're trying to say. And I've just highlighted, just like I did before, this is when the hours it starts, when it peaks, and usually up to how long it lasts within the blood. So the advantages and disadvantages. In terms of the advantages, it's rapid, it's cost effective, yeah, it's a very accurate assay. It's cheaper than troponin. Troponin is much more expensive. And it's very cost effective. Therefore, it's cost effective. It's more rapid than troponin in terms of getting the results fast. And it's one of the accurate assays, decent ones. It has the ability to detect early reinfarction, much like I showed you in that graph just now. So if they have a second infarction and it's within 2 weeks, use CKMB to see the next peak. Okay. But the disadvantage for CKMB is that, again, it's not specific. Skeletal muscle pun has CKMB. And usually after surgery, CKMB can be elevated. Okay. So that's why they use a CK to CKMB ratio, just to make sure that if you have really high CKMB compared to CK ratio, then chances are it's also coming from the heart. Okay. The other one is its low sensitivity during an early MI. During an early MI, less than 6 hours after the symptom onset, CKMB, just like troponin, is just starting to climb. So it still might be within normal range. So you can't really use it effectively if the patient comes in much earlier after the onset of symptoms. So you might not want to use CKMB or troponin. So what do you use? Again, total CK is poor sensitivity, poor specificity, but what they use this is in combination of with CKMB to look at the ratio. Okay, so total CK, you cannot use it as its own biomarker. It should be read with troponin, or it should be read with CKMB. Okay, because total CK pretty much is almost obsolete. But let's say you want to detect very, very early infarct, and CKMB and troponin are really bad at picking those up. So myoglobin is the way to go. But myoglobin, let me remind you, is a really, really bad biomarker because it's definitely not specific, because you can find that pretty much in all muscles. Okay, but it's good at picking up that early marker. And so within that 2 to 3 hours, you will see that it goes up already after an infarction. The only problem now is it goes down very quickly, rapid renal excretion, so it goes back to normal within 24 hours. So the only wonderful thing about myoglobin is it has a good sensitivity because it can pick up a slight increase. And it's high sensitivity in the sense that to detect early MI. Okay, and that's why it's useful to detect early MI. And it's usually a good ruling out MI, to rule out MI. This is what they used before. So if they want to rule out MI very quickly, they would use the myoglobin. But because now we have high sensitive troponin can now be used to rule out MI. Okay, but that was what myoglobin was used for. The disadvantage is it is so poor in specificity because it's in every muscle there is. And the other thing is it has a very rapid renal excretion. So unfortunately, myoglobin returns back to normal. So you can't, if they come in 2 days after the presentation, myoglobin would have been normal and you wouldn't have picked up. Okay. So myoglobin should not be used as a diagnostic marker. It lacks cardiac specificity. So myoglobin is only used if you want to detect early and then later on you would have to confirm with troponin, or you would have to confirm with ECG, for example. Or if, let's say, you want to really know for sure, then you can the cardiologist can decide to proceed straight to an angiogram. So, but it should not be the only biomarker that the clinician makes decisions on whether the patient has MI or not. It has to be confirmed with another biomarker, either a CKMB or a troponin. Okay. So in terms of the complications in terms of the complications of MI, you have the following. So complications of MI, you don't have to memorize this because number one, you just think if you actually caused death of that tissue, you would have remembered the functions that it would have undergone. So for example, the wall houses the pacemaker. So if that aspect of the wall is affected, then you will get arrhythmias. You will get congestive heart failure because it's unable to recoil anymore because the muscles are not there, because it's replaced with fibrous tissue. So eventually the heart will exceed the Starling's law, and then you will no longer have the recoil. You can get cardiogenic shock because the heart just stops or fails to pump. You can get ventricular rupture because, again, when you replace it with fibrous tissue, the wall is no longer strong, so it's very weak. So you can actually cause a rupture, the ventricular rupture, and get a cardiac tamponade. A cardiac tamponade means that the blood comes out of the ventricles and it collects at the can you remind me of the anatomy? Remember, there's a thin layer between the
Pericardium.
thank you, the pericardium. So the pericardial space, right? So the blood goes into the pericardial space, and then you get this cardiac tamponade because when it goes into the pericardium space, it actually constricts the movement of the ventricles. So the ventricles are no longer able to pump. Okay, so you get the cardiac tamponade. Of course, you can actually rupture the septum because that's still part of a weakened wall. And so you can get all the shunting, the left to right shunt, right to left, the left to right shunts, or right-sided overload, which means you can get right-sided failure. You can destroy the papillary muscle because if you have infarction there, and that would cause valve incompetence. You can get the fibrinous hemorrhagic pericarditis, just inflammatory response continuously following the MI. You can have a mural thrombus because, again, the ventricles now are not efficiently pumping. So you tend to get somewhat of a stasis within the ventricle walls that's going to promote clot formation. And so you can get thrombus, and you can have a risk of embolization. You can also get ventricular aneurysms where it enlarges because of the weakened wall again, and you might get repetitive infarction. So those are the complications of MI. Take your pick. If you can't remember all 10 of them, at least remember 5, because usually in any OSPE questions or anything, at most that we might even ask you could be 4. We've never asked 5, but I'll always get you to remember 5 because my professors used to ask me to remember 5. Maybe that 1 is usually the spare in case you can't remember all 5, but at least if you remember the 4. Okay. I think what happened? Oops, sorry. All right. Is my slide moving? No, it's not. Okay. So that's it. In terms of ischemic heart disease, is there any questions that you'd like to ask me?
Yes, doctor.
Sure. Yeah.
My name is Akil, and I have some questions. In the slide of the comparison of onset, peak, and duration of elevation of the cardiac markers, is it? I have some clarification to do. The pink arrow is the myoglobin, is it?
Let me just where's my window? Okay. Right. So we're going to here. Okay. This pink is myoglobin. The brown is CKMB.
And the green one is troponin T, is it?
Yes, the troponin T. So you can refer to this in terms of how it's dotted. Okay.
Also, doctor, is there any specific troponin or both troponin T and I will be elevated during
Okay.
this cardiac, this MI?
Okay. So if you can see there's let's say troponin I, and this is your troponin T. All right. Yeah. So your troponin I and T, they're elevated around the same time, but it's just that troponin I is more elevated than troponin T. Can you see that?
Yes, doctor.
Okay. But for us as clinicians, it doesn't matter, because what we see is it peaks about the same time, it goes up about the same time, it comes down about the same time. So whether or not troponin T is higher or not, because we have the higher sensitivity assay, it would definitely pick these up, whether it be here or here. So in terms of, let's say, which one's better, they're the same. So when we do comparison between troponin T and troponin I, it really doesn't matter. There's no significant difference between the two. You can either use I or T.
So basically, both troponin will be elevated, is it?
Yes, both troponin. It just depends on what analyzer your lab in the hospital is using. Some labs might use this brand of analyzer that that can measure troponin I, and then another lab can only measure troponin T. But they're the same. The only problem is you cannot use them interchangeably. That means you cannot say like, okay, I measured this patient first with troponin T, and now I want to see whether it comes down, so I'll use troponin I. You cannot do that, because it's so much difference. See? So if you start using troponin T on a patient, you have to continue using troponin T if you want to monitor the punya progression. Clinicians like to do serial measurement. Serial measurement means every 1 hour they measure troponin, and because they want to see the rise and fall of the troponin to determine what's happening in the heart. So we will always advise that you do not, once you start with troponin T, stick to troponin T, or if you start with troponin I, stick to troponin I. You cannot migrate from troponin I to troponin T, or troponin T to troponin I. Okay?
I see. And doctor, last question. On the myoglobin slide, the advantages, what does it mean when you stated that it is the most useful in ruling out the MI? Because just now in your lecture, I understood that the most best cardio markers is the cardiac troponin.
Yes. Okay.
And the myoglobin is obsolete because it can be anywhere. So what does the third point means in ruling out MI and the negative predictive value?
Okay. Okay. So the thing about myoglobin is myoglobin, much like the total CK, is almost obsolete. But again, some places will use it because they don't have high sensitive troponin. So what they normally do for myoglobin is patient datang within 1 hour symptom onset or 2 hours symptom onset, they can immediately do myoglobin. And if myoglobin is not elevated, they can safely say, okay, patient tak ada MI. They can rule out. But they cannot use it on its own to diagnose, maksudnya rule in. So in cardiology terminology, they have what is called a rule out and a rule in decision. Rule out means they can safely say, okay, patient ni tak ada MI because myoglobin dia is low. So let's just push her out and you can discharge the patient. So which means myoglobin, it cannot be used as a rule in, but it can be used as a rule out punya mechanism. So that's really what it means, because dia punya, when they calculate, if you notice here, it says increased negative predictive value. NPV, or what's a negative predictive value, is whenever we want to test a marker to see whether it can diagnose or not, we look at the PPV and NPV. Positive predictive value means how good it is to pick up the ones with the disease. The NPV is how good it is to pick up the ones without the disease. And myoglobin, out of all the 3 biomarkers, is really good at picking up the ones without disease. But only the ones that come in less than 6 hours. Okay?
Okay, doctor.
Because after 6 hours, memang myoglobin will be very, very elevated. Cuma they don't have the specificity. So nak rule in tu, you tak boleh kata, oh dia ada positive after 6 hours, therefore dia ada MI. She could have muscle pain. She could have a muscle disease. She could have injured her muscle, and that could cause the myoglobin to go up, for example. So that's why rule in, kalau myoglobin tinggi, they still need to confirm with CKMB sekurang-kurangnya. Kalau tak ada troponin.
Okay, so myoglobin is basically to reject the possibility of MI during early MI.
Yes,
okay.
correct.
Okay,
only rule out,
good.
only exclude. Correct, good.
Thank you.
Okay. Any other questions you guys want to ask?
Doctor, can I ask something, Doctor?
Mm-hmm.
My name is Saleha.
Okay.
Oh, 2 minutes.
Hello?
Yes.
Okay.
Okay, Doctor, can you show back the graph that presents the cardiac markers?
The cardiac markers, yeah.
I want to ask about the reinfarction.
Mm-hmm.
Why, if we think logically, if there's reinfarction, there's going to be more troponin, but why is it not going to be elevated again? As in, there is not going to be two elevations. Why is it going to stay the same?
Okay, katakanlah macam ni ya. I take ni. You see, let's take 5 milligram. That's the cut off. Okay. So if we take 5, the unit 5, and that's your cut off to, that means kalau anything above 5 is abnormally high. Okay, you can see everyone's abnormally high at 5, right? Okay, so let's say this patient had infarct at day 0 here. So your myoglobin will be high, CKMB will be high, troponin will be high, both troponins, okay. So they're all elevated, and then he's in the ward. He's lying comfortably, everything's okay. Myoglobin comes down day 1. So day 1, after day 1 too, myoglobin is normal balik. And then he moves around, he's still in the ward. Day 2, 48 hours, what happened now, he gets a second MI. Okay. By this time, can you see CKMB dah turun below 5?
Yes.
Okay, but can you see troponin has not come down yet?
Yes.
So out of all the 3 biomarkers, only 1 biomarker that doesn't come down. The rest semua dah turun balik ke normal or below that 5. Okay. So when he gets a second infarction kat sini, so you cannot detect it kat sini because they're still high. It's like way high, and you won't be able to see the difference. Okay, but what you can see now is myoglobin goes back up, CKMB goes back up. And that is the one that you can detect. Can you imagine that?
Oh, so that means if there is second type of infarction, that means if the level of troponin is going a bit higher, the previous...
It must.
Yeah, it must.
Yes, it must that infarction. Sebab dia duduk tinggi lagi kat sini. Tak turun-turun lagi. But katakanlah dia ada second infarction somewhere in the 3rd week. He has another infarction. Because chances are usually patient ni, when they have the first one infarct, they can have subsequent infarcts if it's not treated. Ni. Or they can have infarct because kan they go through the procedure, you're still at risk of getting reinfarction. So they can get infarction katakanlah 3rd week. Kalau at 3rd week, you can measure balik troponin sebab dia dah turun, it comes back down to normal at 2 weeks. Okay. So if at 3 weeks, you can already measure, you can use troponin, you can use CKMB, you can use myoglobin to detect that second heart attack. Can you see how we're seeing it?
Yes, doctor. Thank you.
Okay. All right. Okay. Any other questions? Okay. If there's no questions, then if I can get your ketua kelas to ni, I'll share my slides with ni, and then he can distribute the slides. Or are you recording this? Oh, you're recording this. Okay. So if you're recording this, then you'll have my slides in the record. Okay. Is that okay? Any other questions?
Okay, doctor.
Okay. If there's no questions, then thank you very much. Assalamualaikum and stay safe.
Thank you, doctor.
Thank you,
Thank you,
doctor.
doctor.
Alright,
Thank you,
bye.
doctor.
Thank you so much,
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Bye.
Thank you, doctor.